We are live.
Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good evening, everyone. And welcome to the second day of the third series of challenging cases in oncology, which is a monthly meeting that we discuss interesting and learning cases from presented by different oncologists in different disease sites. Today is the day 2, and we have another 3 cases. And it's my pleasure to moderate this session, and also my pleasure to welcome my dear friend and colleague, Dr. Imad Tashkendi, to co-moderate the session with me. Dr. Imad is a consultant medical oncologist, and he's the director of the medical services for oncology department at King Abdullah Medical City in Mecca. And he's assistant professor at Al University. Welcome, Dr. Imad, and please introduce our first speaker.
Thank you, my dear friend, Dr. Mohammed Al Garni. It is my great pleasure to be part of this interesting meeting. And I can tell you, mashallah, tabarakallah, in the past few years and coming few years, inshallah, National Guard Hospital will have the leadership in many things. And we can see that from the type and topics, in addition to speakers. And today we have our star in National Guard Hospital, Dr. Ashwaq Al Olayan, and she will be talking about the HCC case. I'm sure all of us know Dr. Ashwaq, as she's the section head of medical oncology in National Guard. If I'm wrong, please correct me, Dr. Ashwaq. Here you go.
Allah يسعدك. شكرا عماد for the nice introduction. Allah يرضى عليك. So today my case is short, but the flavor is different in terms of looking at HCC from different perspective, from 2 ways. So my patient, he is, let me just minimize this so I can see. This is a 32-year-old who's known to have constrictive pericarditis, which is not really know what's the underlying diagnosis. Is that just viral or other inflammatory disease? But unfortunately, this young gentleman, he developed cirrhosis. And in 2012, he developed multifocal HCC. His alpha-fetoprotein at that time on diagnosis was 3.4. He was a child A, and MRI I cannot display because it was outdated. To 2012, we don't have the films on the updated system. Okay. All right, so the MRI shows cirrhotic liver with no frank sign of portal hypertension, no splenomegaly, no portal systemic shunt, no ascites or mesenteric congestion. He had multiple lesions on the liver. The first one was in segment 5. It was 2.7 by 2.5. And another lesion in segment 2, which is 1.3 by 1.3, a third lesion in segment 7, which is 1 cm, and another small lesion, which is around 8 millimeters, which was equivocal. As I mentioned, he doesn't have any sign of any portal hypertension by the scan. So how frequent we see HCC on liver, how frequent we see cardiac cirrhosis, and how frequent we see HCC on patient with cardiac cirrhosis. Honestly, I've treated hundreds of patients of HCC. That's my first and the only patient through like 12 years of doing pure HCC management. And if we look at the cardiac cirrhosis per se, it's produced by increased the preload and back pressure on the hepatic system and causing congestion, and eventually that lead to cirrhosis. And if you think about that, there is no much of inflammatory. We think the patient might have cirrhosis, but as we all think about the pathogenesis of HCC, that we think that it's probably to the inflammatory process happening by the viral infection. That's why we have a long-standing viral infection like Hep C, or acute or even short-term infection with hepatitis C. And lesser we see NASH, but it's now increasing. But again, we know that the metabolic syndrome can cause a lot of inflammatory process within the liver. But having only congestion, why the patient will develop HCC? There is two publications, one from Ghassan Abu Alfa, I did not mention it here. They report 2 cardiac cirrhosis with HCC, so it's very infrequent. And here among 257 patients, they found these patients, they have cardiac cirrhosis, few patients, they develop HCC due secondary to cardiac cirrhosis. So the incidence of HCC likely to increase in the future because we know that we have better modality of therapy. These patients have better medical management, they might live longer, and we might see in the future more of cardiac cirrhosis. So at that time, we have only sorafenib, it was 2012. We give the patient the treatment for 4 years. In the first 2 years, the patient have complete radiological response. And after that, we put the patient on another 2 years, then we stopped the therapy. As of now, in 2021, the patient on the last scan have no evidence of disease, and his liver cirrhosis managed by medical therapy only. So the patient now, he's waiting for double transplant because he will need a liver and heart because his heart status is not good after the long-standing constrictive pericarditis. So the first question, do we see complete response after sorafenib? Fortunately, we have 4 patients. This is one of our patients. One patient, she got transplanted post. She was non-candidate for transplant, and after she had complete response with sorafenib, she was transplanted. And this patient on the way waiting for double organ. So this is again a trial in 2008, a total of 15 patients who developed complete response. 4 cases confirmed by histological after surgical resection, and the underlying disease was hepatitis C. And our patient in our center, the 4 patients, 3 of them were hepatitis C, except this patient was cardiac cirrhosis. And they have they have infection longer than 6 months, and they have the longest recurrence-free survival of 6 months. Another, we present also another case of 54 patients with hepatitis C who experienced complete response following sorafenib without recurrence for 12 months. Long-term complete response of sorafenib. This is interesting case report of 77-year-old woman who diagnosed to have hepatitis C. And again, hepatitis C, hepatitis C, hepatitis C. That's what we hear, that sorafenib have better response with patients with hepatitis C. I think this is proving a concept. In 1990, this patient have HCC detected. She received ethanol injection. She had a recurrence, microwave. On April, she had diffuse lung mets. And the patient, she get sorafenib with a reduced dose, only the 400. And 4 months post-therapy, she had complete disappearance. And she currently, the sorafenib administration dose and the patient had complete response was maintained for 2 years. So for how long we have to continue therapy? So now we're talking about complete response. So for how long I can keep the patient on therapy? Apparently there is nothing to tell you when to stop, but this is a couple of cases from literature from 1 to 15 cases. So the duration of stopping the treatment was 6 months to 16 months. And none of these patients relapse. So we can stop sorafenib after complete response, yes, but looking at this variation of between 6 to unknown time, probably 1 year, maybe it will be the treatment that I'll give the patient. For another year. If he had complete response, I'll stop the therapy. So that's it. Thank you.
Okay, Matt.
All right, thank you, Ashwaq. Now we can look at the chat box if there is any question. And until then, I can ask you. Now, can you tell me more about what do you mean by cardiac cirrhosis? Like the patient does have a history of heart failure or something like that? And if so, what's the ejection fraction?
He was having constrictive pericarditis. Honestly, Ahmad, I cannot recall his ejection fraction, but he had a long-standing constrictive pericarditis, and he was not following in our hospital. He was following in King Faisal Specialist Hospital. When he developed HCC, he came to our hospital. Then we start follow-up. And, you know, like the cardiac transplant is not still well developed in our center. We shipped him back again for transplant. Unfortunately, the waiting list for heart transplant is long. So he's a candidate for double transplant, and we sent his paper even outside the country. So I don't think that's related to ejection fraction. It's related to the backflow pressure, which happened because of pericardium. It will be like stiff, and the backflow will make congestion to the liver. And we do see patients with heart failure, as you mentioned, liver cirrhosis. But this guy, he's too young. He's 32-year-old. So heart failure was not one of his diagnoses.
Okay, thank you. Mohammed?
Yeah, thank you, Dr. Ashwaq. This is a very interesting case. So as you know now, the BIF and atezo is becoming the standard for advanced non-resectable HCC. So what are the set of patients that you still consider sorafenib? Is there any data that or predictors that sorafenib may work for certain set of patients rather than others?
I think for the current practice, every patient is a candidate for atezo-avastin unless there is a contraindication, which is post-transplant, patient with autoimmune disease, patient have bad varices that they have a risk of bleeding, or they have bleeding before. These patients we might exclude, and now they talk about NASH, and they may not be a good candidate for atezo-avastin. In these cases, number one will be atezo-avastin. But in this patient, if he had recurrence, and again, he had a good response to sorafenib, what do you think? I would think of, I'm going to put him back onto sorafenib. What do you think, guys? If you are the oncologist and he had a recurrence, what are you going to do for all of you guys?
I would give the therapy that he responded very well to. I mean, it's very unique. I think, Dr. Ashwaq, that he actually had a complete response. We know it's very rare with sorafenib, and we know that objective response rate is quite modest. I do not recall the exact number, but I'm pretty sure it's less than 20%. So 1 in 5 patients actually get some tumor shrinkage. So to actually get a complete radiological response, this is remarkable. So I would reuse the same active agent that he responded to.
Yeah, in 7 years. He's off therapy for almost like 6 and 7 years. He's cancer-free.
MashaAllah.
So do you think, Dr. Ashwaq, this is really the effect of sorafenib, or it's related to the biology that is related to cardiac cirrhosis? Does patient with cardiac cirrhosis has a better prognosis, although they are, you know, very rare and no much cases? But do you think maybe this is related to the biology rather than the sorafenib itself?
Well, Mohammed, I wouldn't be sure because I have only one patient and the literature have a few patients. So probably we don't have enough data, but we know for sure that patients with hepatitis C, they are the patients who have a complete response. And I show you a couple of patients, but there is tons of case report. I think we have more than 10. And I presented one of the meeting that they have complete response. And in one center, our center, we have 4 patients, and 3 of them were hepatitis C. So I think definitely hepatitis C probably one of the factors that have better predictor to sorafenib.
On the same line, what do you think of volume disease in this gentleman? Do you think he's got the low volume disease or high volume disease? And is that going to be affected by the sorafenib or no?
Yeah. This guy, you can say that he had a low volume disease, although he had a multifocal lesion, and it was 4 lesions. At that time, none of the intervention were interesting of going after each lesion by a local regional therapy, although he would be a candidate for local regional therapy. But fortunately, he did well on a systemic therapy. Would that have a better response? I think it's a general idea in oncology. Whenever you have a less volume of the disease, the response rate will be definitely better when you have a bulky disease.
And what do you think of the age? Younger?
Yeah, the age helped, although he was not receiving the full dose. I did not give him the 800. All my patients, almost like 95% of my patients, they have the 400 doses only because they cannot tolerate. He's very thin. And you can tell that he'd been sick for a while because you can see that he had his growth was not like the normal adult. He was short status. He was different. So I'm sure he had this cardiac disease when he was very young. Maybe it was missed and was missed and diagnosed. That's why he developed the cirrhosis, unfortunately.
Okay, so Dr. Ashwaq, there is some questions in the Q&A. One of them is related to the diagnosis, because one of the comment, we don't have the name, but he said with this scenario, he would suspect the diagnosis. So do we have a biopsy to confirm the diagnosis, or it's just classical HCC appearance on CT scan?
It was frank cirrhosis, the liver was shrunken and it was luxuriatic and the lesion was having the typical feature. I showed the MRI, but the patient have CT scan, which confirmed with MRI 2 diagnostic method that he had an HCC.
Okay.
One of the question also, would you give a patient with embolized tumor bleeding Avastin?
After embolization, you mean?
Yeah, this is the question.
If the patient is active bleeding, I think embolization #1. But after embolization, if he's stabilized, why not? If there is no risk of bleeding, small tumor, it was not on the surface of the liver, I would think of giving atezo Avastin, but not immediately after embolization. I might start with atezo alone, then I might add Avastin.
Dr. Ashwaq, I have a question, please. If we have this patient now, and we have now a lot of medication for HCC, immunotherapy, sorafenib, and lymphatic, what you will select for this patient now, especially with cardiac toxicity with sorafenib? As we know, it's increased risk of myocardial infarction, and he had cardiac issue. What's your advice if we have this patient now?
I would go with atezo Avastin because it has the best response rate so far. That will be my first choice. Lymphatic, because the bulk of the disease was not significant and he's already thin. And we know like losing weight and decreased appetite is very high with lymphatic. So my first preference will be atezo Avastin, definitely.
So one more question, Dr. Ashwaq. So regarding the diagnosis of HCC, so what is the scenario that you still insist to get a tissue diagnosis?
Okay, if the patient doesn't have a feature of cirrhosis, although if the radiologist would tell you this is characteristic of HCC, the arterial uptake and the venous washout, no, I will still take a biopsy if there is no cirrhosis. The only indication if there is no cirrhosis, if the patient have hepatitis C, we know that they might develop HCC without frank cirrhosis by radiology. That's the only time that I would I will agree on the radiology. Otherwise, in any other indication, if there is no evidence of cirrhosis by radiology, and if you're not convinced, you can do another modality. Everything is not convincing of HCC neither by radiology, and the patient is maybe the patient cirrhotic, but the lesion doesn't look like HCC by radiology, I will take a biopsy.
On the same line, is there any other imaging modality you would select in this patient?
They were talking about the ultrasound, the contrasted ultrasound, but it did not grow. Initially, everybody was interested that it might give addition to the diagnosis, but it did not work. So if you have a CT scan, you can complement this with MRI, but if the CT scan is convincing, you don't have to do an MRI for these patients.
Right, and for these patients who are young, are you aware of any genetic disease that can be linked to or maybe tested for?
Not for HCC in particular. Yeah, I'm not aware of any genetic test. We have our genetic guy here, Mohammed. Are you aware of any genetic disorder associated with HCC? I don't know, honestly.
Yeah, I don't think there is a syndrome that is the HCC is considered one of the cancer involved in this syndrome. But there are certain syndromes that can cause HCC as a complication, like hemochromatosis. Especially the hereditary one. This is what can come in my mind, but most of the time HCC is secondary to something like hepatitis or NASH nowadays. Okay, there are many questions in the so for the fibro-lamellar HCC, any different approach?
I've been asked this question in every meeting live, but the question that how frequent we get the diagnosis, because we can miss this diagnosis by not doing the tissue. So maybe we treated a couple of patients, and I know there is a data that probably in immunotherapy is not the best for these patients, but it is very short limited data for these patients. Again, if I have this patient, I don't have enough data to support any approach, I would again treat it as an HCC. Definitely, I'm not gonna go of giving chemotherapy for these patients.
So Dr. Ashwaq, one of the attendees, also he mentioned about in the era of immunotherapy, he thinks that histopathology is mandatory because otherwise we'll have many cases like this. So do you agree that we should still have tissue diagnosis because we are just,
I think we need tissue diagnosis, but it might help if we gonna do maybe further tests within the tissue. But having the tissue per se, just for confirming the diagnosis, I think we missed some HCC and cholangio, which is it messed up. I have a patient who get transplanted as an HCC and turned to be cholangiocarcinoma. So it's totally different pathology, but radiologically it was convincing. So do we miss cases? I think the certain diagnosis is in the pathology, not on the radiology, but yet we don't have enough data that we should do pathology for each patient. But maybe we can do these for the patient who are progressing very fast on therapy and they are still doing well, especially when we see hyperprogression with immunotherapy. Maybe you need to take a diagnosis and to test these patients specifically, because you might have a different approach for them or might do an NGS and find a different mutation, although we know NGS does not work well with HCC.
Yeah, this was the point that I want to ask you about. So if you have, fit patient who progressed in a standard line of therapy, do you see a molecular profile for the tumor in value on patient with HCC?
Well, Mohammed, when they did that, they did like more than 100, I think 200 plus molecular tests for these patients or genetic looking for a mutation. And the only things that they find the common one, which is the P53, which is, it's so what? It's in almost all cancer. And the beta-catenin pathway, which is we have no target for that. So the commonest things in HCC have no target. So it was a failure. So it's been tested a couple of times and there is a clinical trial about that, but it doesn't work. So, but maybe certain patients have a certain mutation that we see like in our patient, that we find a mutation like yesterday in sarcoma, we would never thought of treatment option will work. So I would encourage doing this for these patients, that they're fit, they're okay, they fail standard therapy, and we have no option. And fortunately in HCC, we have too many line now, so.
All right, in 2021, who is most suitable for sorafenib?
Okay, like if we make TKI at one place and immunotherapy in another place, if the patient not a candidate for immunotherapy, sorafenib will be number one. Sorafenib, lenvatinib, I hate lenvatinib. Kenan, he knows that.
Kenan, you want to say something?
So with regards to who would I give sorafenib, probably in 2021, is patients with child B7 cirrhosis. So if your child Pew score is B7, I probably would not give you the Embrave 150 regimen, and I would not give you lenvatinib as per guidelines. I know there is probably developing body of evidence that says that maybe patients with B7 can be given lenvatinib. It's probably real world data, but as per the clinical trial, they did not give patients with child B7. However, I think with sorafenib, it's been in the market for more than a decade now. There are publications that say that you can actually give it to child B7. So if I'm given a patient with child B7, I'd feel safer giving them sorafenib rather than lenvatinib or the Embrave 150 regimen.
But nivolumab, on the trial of the nivolumab, they give the child 7. So I don't think immunotherapy is risky for a child score of 7. I give 7.
Yeah, I think what we were, or the question is about first line. So I would not really give the patient probably nivolumab in the first line unless in very select cases.
And because we have different audience, maybe it's also dependent on the resources that you have. And if you're in a country that can offer immunotherapy, of course, the immunotherapy is
absolutely.
So the last question for Dr. Kanaan and Dr. Ashwaq. So this patient is planning for transplant. So HCC in transplanted patients, what would be your choice of therapy?
Post-transplant.
Yes.
Post-transplant, the only treatment you cannot give is immunotherapy, but the other TKI, definitely it is safe. It depends on the patient tolerance post-transplant, and my experience with post-transplant was not good enough. So these patients, sometimes when they play even with immunosuppressive therapy, and as I've told you, we have patients with complete regression of the tumor or lung meds without therapy, was when they would use their immunosuppressive therapy. So it is a bit tricky. My first choice would definitely be sorafenib, not lenvatinib, because these patients are weak, and other modality like ramucirumab can be given if the alpha-fetoprotein is high. And again, if you have oligometastatic disease, I would think of local regional therapy like SRS to treat these patients and to avoid any systemic therapy. Kanaan?
Well said, Dr. Ashwaq. I have no further addition.
Okay.
Right, I think that we're doing great. And back to Mohammed.
Okay, so thank you, Dr. Ashwaq. Now we'll move to the second case, which is again an HCC case. It will be presented by our dear friend and colleague, Dr. Kanaan Shamari, who's a consultant medical oncologist who is seeing more mainly GI and sarcoma, and he is our phase 1 clinical trial expert, and he will talk to us about another HCC case.
Thank you, Mohammed. Are you guys seeing my slides? Thank you. So I thank the organizers, Dr. Mohammed, Dr. Ashwaq, for asking me to present a challenging case. So I recently had a challenging hepatocellular carcinoma case. So Mr. OA is an 80-year-old man who was actually referred to my clinic from the hepatology service as a liver mass, or actually he was referred to the hepatology service as a liver mass for investigation. He did have a background of cirrhosis, likely NASH-related, definitely not secondary to viral hepatitis. He did have diabetes, which was diet-controlled, and hypertension. With regards to his medications, he was on amlodipine 10 milligrams once daily. He had no drug allergies. So he was referred from a referral hospital with an abdomen ultrasound showing a liver mass after he presented with some sort of non-specific abdominal pain. So he was seen by the hepatology service. They started the workup. His hepatitis serology was negative once it was ordered. And he did have a triphasic CT, which showed a cirrhotic liver. It showed multiple liver masses. Some were LIRAD5, and others were not really typical of hepatoma. This is one of the baseline images of his liver. So he was presented at our local hepatobiliary tumor board. He was not found to be a suitable candidate for local regional therapy or surgery. So he was referred to our clinic for systemic therapy. So he came to me. His performance status was excellent for an 80-year-old. In fact, his performance status was 0. And his child Pew score was actually 5. So he was A5. So we requested a CT of the chest to complete his staging, and he was found to have a right upper lobe mass that was 5 centimeters in greatest diameter. So I discussed, so I'm showing you here the mass. So I discussed this with the radiologist, and the impression was that this could be a second primary. So another discussion with our interventional radiology colleagues, and they agreed to biopsy this lesion. And after biopsy of this lesion, the pathologist reported it to be a neuroendocrine carcinoma, small cell type, with a high Ki67 of 70%. Now, I also discussed this with a couple of my dear colleagues at abdominal imaging, and their opinion was that some of the of the liver masses that were not typical of HCC, they are likely metastases from this neuroendocrine carcinoma of the lung. So how would you approach such case? So you have 2 malignancies, probably synchronous double primaries. Both of them are metastatic. Is there any potential of cure? Probably not. So one of the approaches that we use when we are faced with 2 cancers is the impending risk or the priority approach, which I'm going to talk in detail about in the next few slides. So I did discuss this patient at the hepatobiliary meeting and our thoracic tumor boards. And I also discussed this patient with one of our thoracic oncologist colleagues. So with regards to prioritization, which means what is the highest risk from these 2 cancers? He does have a risk of death from his neuroendocrine carcinoma, specifically this being a small cell type with a high Ki67, which is quite aggressive. There is a risk of progression from his HCC. There's also a risk of liver dysfunction and decompensated cirrhosis. When he came to me, he was child Pew A, and he was A5, in fact. So at our MDT meeting, the collective decision and provisional plan was we were not going to give this patient local regional therapy upfront with his aggressive neuroendocrine carcinoma. He definitely needs systemic therapy. We should select systemic therapy that has the potential to cover for both your neuroendocrine carcinoma and HCC. We decided that we need early reassessment CT scans to check for response and to change the plan accordingly. And I've explained this plan to the patient and his son, who agreed on this provisional plan. Now, one of the publications that spoke in detail about challenges of dealing with multiple primary tumors. I do encourage the audience to look at this. So it touched upon when you're approached with double primaries, you should always think about risk factors. Are there risk factors to develop both of these primaries? One of them is genetic and familial syndromes, which I would not really think about in an 80-year-old who presented with this. Prior cancers or therapy, we know certain systemic therapeutic agents dispose you to certain cancers. Radiotherapy can predispose you to certain cancers, such as radiation-induced sarcoma, and lifestyle factors that may be risk factors for both cancers. Examples are smoking, obesity, alcohol, and others. Multiple publications actually looked at the frequency of having multiple primaries from different databases. And I think the range was between 2 to an average of up to 8%. Now, how do you approach therapy when you have synchronous primaries. So as I mentioned before, they should be discussed in multidisciplinary team meetings, and a consensus decision on therapeutic strategy can sometimes take more than one MDT to form, such as in our case in the hepatobiliary meeting and the thoracic oncology meeting. Also, the patient should be well aware that the situation and therapeutic challenges are coming due to the uncertainty of the prognosis and the challenge of being approached with two primaries. Now, if you have localized disease, meaning two single primaries, then the strategy could be to approach the patient with radical therapies such as surgery, radiation, or chemoradiation with the aim of cure or long-term remission. However, in the situation of advanced disease, we should always think about systemic therapy that covers for both types of cancers, and this may not be from evidence or clinical trials. So we should always think about what would be the tumor that has the worst prognosis and which of those tumors is probably more aggressive. Now, is there a chance to cure one malignancy, or is the approach going to be palliative for both malignancies? Do we know the tumor dynamics, i.e., does one tumor grow more rapidly than the other, and does it need to be targeted first? And should the treatment strategy be a mixture of local and systemic therapy, or systemic therapy alone? And we should always think about what problems could be anticipated. So examples, if you have colorectal cancer, is there a risk of obstruction, and do you actually need to divert your patient before starting on therapy? If you have extensive liver metastases, could targeting those liver metastases early on help prevent liver failure? Tumor profiling. Would tumor profiling be beneficial? Would you actually find a single mutation or a genetic predisposition that could be targeted with certain systemic therapy that would cover for both of these cancers? Now, if you think about systemic therapy for two different malignancies, you should always think again about which one is the most aggressive one. If, for example, in our case, the neuroendocrine carcinoma would be the most aggressive one, would you actually give a therapy to only neuroendocrine carcinoma, small cell type with high Ki67? And would you think about treating the HCC with neuroendocrine carcinoma in a cycling manner? Meaning, would you give for example, cancer A, systemic therapy for 2 to 3 cycles, followed by cancer B, giving it its own systemic therapy for 2 to 3 cycles. These are all questions that should be thought about when you're approached with double primaries. So back to our patient, or actually before going back to our patient. So neuroendocrine carcinoma, small cell type, high Ki67, we always think about it as behaving like small cell lung cancer of the lung. So what are the therapy options currently? Platinum etoposide plus durvalumab, platinum etoposide plus atezolizumab. We know from recent evidence that the addition of immunotherapy to platinum doublets did show improvement in outcomes, specifically overall survival. Now, in our case, can we add anti-HCC therapy to this regimen? Is there evidence of adding tyrosine kinase inhibitor to platinum doublet? I would be worried about toxicity. What about giving anti-VEGF with platinum doublet? Is it probably the right approach? For me, probably not. So I'll take you to our next slide, which I'm going to discuss what therapy we have chosen. So I chose carboplatin etoposide to cover for the neuroendocrine carcinoma and atezolizumab, which has evidence to be active in small cell lung cancer and has evidence to be active in HCC. So I did discuss with the patient that he has 2 primaries. His performance status was excellent, despite his age being 80 years old. And his liver function tests were actually preserved with him being child A. Now, before he actually came to my clinic, the hepatologists have actually done an EGD, which showed grade 1 esophageal varices that were not significant. So I started him on this regimen, carbo, etopo, atezolizumab. So I gave him 3 cycles and I re-imaged him. And the CT report mentioned that he did have some sort of a mixed response, with the neuroendocrine carcinoma having a partial response and the liver lesion. Some of them were actually larger, some were smaller. I discussed with two of my radiology colleagues, and the impression was that the metastatic neuroendocrine carcinoma to the liver lesions, these lesions were actually smaller. However, the HCC component in the liver actually progressed. There was a suggestion early on of doing a choline PET CT. However, this was not available at that time. So I took this patient back to our hepatobiliary tumor board. Patient remained in good performance status, and the interventional radiologist agreed to give him palliative transarterial radioembolization to control the HCC. Now, I put the report of his first disease assessment CT because I want to show the audience how helpful your radiologist colleagues can be. And I'm going to read it plainly, just as it was written. So the radiologist mentioned that this patient has received 3 cycles of chemoimmunotherapy for a neuroendocrine tumor and HCC. He had early cirrhotic liver with uptrending in alpha-fetoprotein, so it increased from 650 to more than 1,000. The hepatic lesions showed different behavior on the current study with different responses to treatment. Some showed response with viable enhancing components, and others have increased in size without internal enhancement, and there are new hypervascular lesions. So the radiologist comment was that we believe that the large lesions are neuroendocrine tumors, while the smaller hypervascular lesions were HCC. And I really think that this is a helpful report, and it's always helpful to actually discuss with the radiologists. So he did have his first session of sequential or staged tear. I actually stopped the atezolizumab because he progressed on the HCC component. And I thought about what anti-HCC therapeutic agent would I choose? Would I actually give him TKI, or would I think about something else? Now, with his alpha-fetoprotein being more than 1,000, I actually chose to give him ramucirumab with carboplatin and etoposide. So I gave him 3 more cycles. He had a second session of tear. His latest disease assessment CT in July showed him to have a complete response in his liver. Now, he did have a significant partial response in his lung lesion with a remarkable reduction in size and a small residual. So I took this patient back to our thoracic MDT, and I discussed with our radiation oncology colleagues, and they agreed to actually offer him consolidative radiotherapy to this lung lesion. We stopped systemic therapy, and he is actually currently receiving his radiotherapy. So some of these discussion points that we think about in these cases is that should we probably have biopsied his liver lesions initially? Now, I did want this to happen. However, I discussed with our interventional radiologist colleagues, and they thought against that initially. Would the availability of choline PET help us? Specifically when we have a mixed response and we have 2 different diseases, one of them being HCC. What would be the best systemic therapy regimen for those 2 primaries? And what would be the best second-line therapy for HCC when you are giving an or you're thinking about giving an anti-HCC therapy in conjunction with carboplatin etoposide? So what did we get out from this case? I think one of the things that we learned is that concomitant malignancies require careful planning and prioritization of therapy. Input from involved services is essential. So interventional radiology, in our case, radiation oncology colleagues, our radiologist colleagues, and others. Sequencing of therapy based on prioritization. So us going for the neuroendocrine carcinoma first, because it's the most aggressive. And of course, taking into consideration the patient tolerance, specifically in someone who's actually 80 years of age, is very important. When these strategies are done successfully, they can perhaps yield excellent results, such as in our patient. And by that, I conclude. Thank you.
Thank you very much, Kanaan, for this really interesting case. So you took us to another age group, so from 30 to 80 years old. However, it's really interesting case. So maybe I will just need to emphasize about, I like how many times you discuss this case in MDT. I think this is very beneficial to our patients, that you seek opinion of other people, because sometimes what you might think it's not doable, other people who has the experience, they can help you and guide you on that decision. So really, I like the multidisciplinary discussion in different tumor boards. So my first question, Kanaan, is, so the patient is 80-year-old. Is the age as a number matter for you, or just the patient's other comorbidities, or the patient, how fit the patient is?
So excellent question, Mohammed. I think as oncologists, we know that we should not be ageist. I mean, by numbers, he is 80. However, biologically, he did not look like he's an 80 years old. He was a fit old man who actually drove more than 6 hours alone to see me in my clinic during appointments. So he was a fit man, and I think we should not judge a person just by age. We should always look at the functional status, and I think this is most important.
Very nice, Kanaan, صراحة, very interesting, and you did a great job. Especially you worked as collaborator, communicator, and even medical oncologist. Now, if I put you on another category and put you as a phase 1 clinician, so in those type of cancers, based on what and how would you design a clinical trial phase 1 for double primaries?
So excellent question, Imad. Unfortunately, most early phase trials actually rule out patients with double primaries. The reason being is most of the early phase clinical trials are actually biomarker based. So they look at a certain disease or a certain biomarker that is available in different diseases. And we are going to speak about precision medicine. We will be speaking about precision medicine in our upcoming meeting that is happening in 2 weeks' time. And I think looking at genomic profiles, looking at certain mutations that may be abundant in different cancers is probably the way that oncology research is probably progressing. So looking at a certain mutation that may be available in different cancers. A perfect example of this is the NTRK story. So NTRK is not a mutation that we look at in one disease. In fact, it may be available in different diseases, and based on the availability of the mutation is when you would give your patient a certain drug. Another example is your MSI and your TMB story. Having an approved drug, so pembrolizumab being FDA approved, regardless of what tumor type is the patient that you're treating. So if you have an MSI high tumor or a patient with a TMB of more than 10, then you have an FDA approved drug to be able to give them.
So you mentioned one of your slides looking at pathways. So in your mind, anything they share, lung cancer, small cell carcinoma, and HCC, so you could target?
So to be honest, I can't think of, probably because of the availability of HCC. The problem with HCC, probably a historical problem with HCC, is that this disease has been, even until recently, is a radiologically diagnosed disease. So we rarely actually have tissue. Now, when you don't have tissue, you don't have trials that are based on molecular profiles or certain targets. Now, there are probably developing studies that are looking at doing NGS, specifically liquid NGS on HCC. However, have they actually looked at a certain target that is available between, for example, neuroendocrine carcinoma and HCC? To be honest, I don't recall.
And I have a question. If the patient fail ramucirumab plus the combination, what will be your third line?
So if they failed the ramucirumab and the combination of carbo-itopo? Well, Ashwaq, I did not really think about this, but the patient responded beautifully to the neuroendocrine component. He's in fact in CR, and we know that neuroendocrine carcinoma, high Ki-67, is chemo-responsive. So if the patient progressed less than 6 months, I mean, he is 80, but his performance status is excellent. then I would think about chemotherapy to target the neuroendocrine component. If he progressed from a neuroendocrine component after 6 months, then I would think about recirculating the same, so carbo, topo again. If the HCC component progressed, then I would have exposed my patient to an immunotherapeutic agent, so a checkpoint inhibitor, atezolizumab, an anti-VEGF agent with ramucirumab. Probably the only option that I would think about is a tyrosine kinase inhibitor. Now, giving it concurrently with chemotherapy is going to be another challenge. However, it really depends on what component actually progressed. So I think this challenge is probably going to come up to me in clinic very soon because we know the behavior of neuroendocrine carcinoma. However, we'll probably target it when it happens.
I think your combination in the first and second line, it was a smart combination. I wouldn't think of any different option other than this. So it's well done, Kanan.
And we have questions from the audience. What is the role of choline PET scan and how do you follow this patient? Are you following this patient with FDG PET?
No, so I'm following the patient with our conventional CT scan with contrast. Choline PET, and it was suggested by one of our radiologist colleagues, and choline PET, so not FDG PET, can actually help us determine the HCC component and whether I think the HCC component actually progressed. Now, we are really limited by availability of certain nuclear compounds. And I think you face this challenge also, Mohammed, since you are our neuroendocrine expert, by the availability of DOTA scanning and so forth. So I think this should always be a discussion with you and your radiology colleagues, which I have done, I think, nicely in this case. Would I follow this case with FDG PET? Probably not, because conventional CT scanning with contrast actually helped me. And the interpretation of the radiologist or our radiology colleagues was, I think, spot on. Another question, and I'm sorry, I'm actually reading the questions here, Mohammed, is do I think that NGS is indicated in this case? That's a tough question to answer. I'm not sure. Patient is 80. What's his prognosis? We know that neuroendocrine carcinoma, high Ki67, so poorly differentiated neuroendocrine carcinoma, their prognosis, unfortunately, is not good. We know that they respond beautifully to chemotherapy early on. However, we know that most of them actually recur within less than 1 year. Would I do NGS? I haven't decided yet. Patient is 80. He has a bad disease. We did well initially. Are we going to do well with time? Time will tell. NGS, unfortunately, is not cheap. It is expensive. Us as oncologists, we should always think about choosing the right test and choosing a cost-effective test on the appropriate patient. So if this patient perhaps was a younger patient, and again, we're not ageists, but if the patient was a younger patient who did not have this bad combination of neuroendocrine carcinoma, high Ki67, then perhaps we would consider NGS.
And Kanan, as I mentioned yesterday, the most common mutation for those with poorly differentiated neuroendocrine tumor is the TP53 and KRAS mutation, which we don't have, effective therapy so far for that mutation. Yeah. So I think by this we'll conclude the second case. Thank you very much, Kanan. It was very nice. And now back to you, Imad.
Well, marvelous cases, marvelous speakers, marvelous discussion points that are very rich, to be honest. And this will not be completed without talking about challenging case during pregnancy. And I'm very pleased to introduce the next speaker, Dr. Omar Al-Shair, who is a medical oncologist in Security Force Hospital. He will give us more insight about the challenging case in pregnancy.
شكرا دكتور عماد. بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. I'm happy today to talk about a challenging case with cancer during pregnancy. This case, actually, it's a mutational case. we deal with her Security Forces Hospital. But before I talk about this case, I will talk a little bit about cancer during pregnancy. As we know, it's a rare and challenging condition. Cancer during pregnancy should be promptly identified and treated. Not only standard of care guideline for underlying disease are taken into account, but also fetal safety might be weighted for a clinical decision. Frequent lack of experience and knowledge about this condition could lead to late diagnosis, affect management, suboptimal treatment, and fetal and maternal harm. My case, she's a 43 years old woman, 23rd week pregnant with her second child after in vitro fertilization, presented with rectal bleeding and mucus, diffuse left-sided abdominal pain. Colonoscopy revealed a non-obstructive tumor in the sigmoid colon, compressing 2/3 of the circumference. A biopsy was taken, showed moderate to poorly differentiated adenocarcinoma, no microsatellite instability, NRAS mutation, KRAS and BRAF wild type. CT scan of the thorax and upper abdomen showed 23rd liver metastasis and small non-specific lung nodules, as we see in the picture. MRI of the liver showed multiple metastases in all liver segment, the largest 60 millimeters in diameter. Pelvic MRI showed 7 centimeters long sigmoid tumor with regional lymph node metastasis and vessels invasion, but no extra metastasis. As we know, we use all these modality with pregnant dose. CAA was revealed as 64.7 high, hemoglobin 10.3, ALT 77. Otherwise, laboratory tests were mostly normal, including the WBC and alkaline phosphatase. What to do now? The case was discussed in specially composed multidisciplinary team meeting with colorectal surgeon, obstetrician, oncologist, and neonatologist. MDT, because the patient continued to have bowel movement, upfront surgical resection of primary tumor was not deemed to be necessary. The surgeon سحب يديه على قولتهم بالعربي. Owing to multiple liver metastases in all segments, we think about palliative chemotherapy, and the hepatobiliary team concurred with no or currently non-resectability of the liver metastasis. Patient and her husband were thoroughly informed of cancer diagnosis and stage, the non-curative intent of the treatment, the rationale for treatment recommendation, and the risk consideration for patient and the fetus. She consented to receive chemotherapy during pregnancy. She started chemotherapy with modified FOLFOX in full dose in week 26 of her pregnancy. Ondansetron and hydrocortisone were given as antiemetic. After 2 cycles of modified FOLFOX, MRI showed size reduction of all liver metastases, the largest measuring 40 millimeters. Chemotherapy was well tolerated by the patient with no serious adverse effect, and FOLFOX was continued without dose reduction or delay. MRI showed further tumor regression, the largest metastasis, as we see, 23 millimeters, and CAA level dropped to 6.3. Patient had regular follow-up by senior obstetrician almost weekly from the time of cancer diagnosis and throughout pregnancy. Ultrasound examination showed normal growth and development of the baby with no sign of placental insufficiency. Patient medical condition was considered good during the whole pregnancy. The child was delivered by elective cesarean section in gestational week 34. The recommendation for early delivery was related to her cancer diagnosis and high physiological burden related to the pregnancy and metastatic disease. After delivery, she received medication to suppress her lactation. As we know, chemotherapy is contraindication with lactation. The child was healthy with birth weight according to gestational age and was admitted to neonatal intensive care for a few days and discharged from hospital after a week. And they name him Omar, same like me. During cesarean procedure, colorectal surgeon examined the abdomen and sigmoid tumor, and no sign of macroscopic lymph node metastasis or peritoneal carcinomatosis were observed. After delivery, CT scan revealed no further metastasis. Owing to good treatment response and tolerability for Folfox, we resumed Folfox 4 weeks after delivery. After 4 cycles of Folfox with further partial response, she underwent laparoscopic sigmoid resection with colostomy. Pathological examination revealed no residual tumor, YBT 0N0. Chemotherapy was continued, and owing to exceptionally good response, she underwent left-sided hemihepatectomy with additional resection and ablation, including the reveal of 20 small lesions. Later, she underwent resection for 4 remnant lesions and wedge resection for solitary lung metastasis. She stayed 2 years free of disease, and unfortunately, after 2 years, she had recurrence with metastasis to liver and abdominal lymph node, and she is currently on FOLFIRI plus panitumumab and going cycle 8. The child now, he's 3 years old, and the patient reports that the child attend routine follow-up and developing adequately according to his age. Thank you. This is my case, and we can open discussion. Thank you.
Imad?
ما شاء الله تبارك الله يا عمر صراحة with this case we can say medical oncologists can deliver good news.
Alhamdulillah.
All right. Now I'm going to ask you like a simple question. Who should make decisions for such cases? Is it the medical oncologist like doctors or family and patients?
I think all of us, and not only me as a part of physician, we need gynae, obstetrician, pediatrician, psychologist, surgeon, colorectal surgeon, and the family. And one of our MDT meeting, we bring the patient and her husband to stay with us, and we bring translation to understand what we say.
Because let's say if this case was in the first trimester.
If it's first trimester, we cannot give chemotherapy, or we cannot give chemotherapy in this condition, as we know the risk of fetal problem higher in first trimester, more than 14% when we compare it to second and third trimester, up to 3 to 4%. All of us, we know chemotherapy, slow molecular particles can cross the placenta and make harm for the fetal. In first trimester, usually we advise the patient to do medical abortion.
Exactly.
Even if, yeah.
So who would make that decision, abortion? Is it the doctor?
The doctor, and it must be accepted by the patient and consented.
I find it very tough, to be honest. I'm not sure if whatever decision we give, but unfortunately, that's something we do.
Yeah.
Mohammed?
Yeah, thank you, Omar. This is really an interesting case. So I think also what is interesting in this patient that most of the time we are very keen to know about the result of the RAS and the BRAF and MSA, because we are eager to add biological agent, but sometimes simple chemotherapy can do a significant job. This patient achieved CR in her primary tumor, which is really something that I like in this patient. So after the patient delivered, so I think you will counsel the patient that the pregnancy is contraindicated, okay? So this is for colon cancer patients. So let's take this broader, Umar. So what about breast cancer patients? Would you approach them differently or it's the same?
Actually, it's a difficult question because sometimes, as you know, the breast cancer is difficult. It's different type. We have triple negative, we have ER/BR positive, and all of us, we know breast cancer, usually it's higher rate with pregnancy due to hormonal change. But I think it must be, we must be deal different little bit with breast cancer. Especially we cannot give hormonal treatment during pregnancy, tamoxifen or this stuff. I think the modality will be changed a little bit, yeah.
Let me check the question and answer box. So there is a question here from Anas Al-Ghazi. Would be the site of the tumor left versus right would affect the treatment choice in first and second line?
During pregnancy, no, because I cannot give cetuximab or panitumumab, even Avastin, because all of them, it's contraindication of pregnancy. We give the backbone of chemotherapy. It's same in right and left side. It will not change our treatment.
And can anyone remind me if all this information we are trying to deliver to patients are based on level 3 trials or just based on information we know?
Just I think from my small search about this, the number of patients with the cancer with the pregnancy is very limited and rare. The rates 11%, 11 per 100%. For this reason, no clinical trial or phase 3 trial give us information, just clinical experience and limited cases.
Can you're close to the mic. You want to say something?
Absolutely. I actually want to congratulate Dr. Umar for excellent management, great outcome for the patient. Child is now 3 years old. And I actually want to echo what you said, Dr. Imad, about who actually would decide on whether the woman, specifically when you're approached with a lady in the first trimester, if she should abort and you should target the cancer or think about systemic therapy. It's a tough decision, and I don't think that the oncologists themselves alone would promote such decision without discussion, probably at a multi-D, specifically with involved personnel. So a high-risk OBGYN, the oncologist, and different other services that are involved in such case.
I have a case, as Kana mentioned, she was in the first trimester and she was having metastatic RCC. And we did a meeting, us with the gynae, and we figured out that he have no chance except to doing abortion. So we did a medical abortion and we started her therapy. Unfortunately, she lived for 2 years, but this is like probably 12 years back. So we don't have good options for RCC like we do have now. And I think Umar, what he did, it's great. And it helped the patient. And I have similar case. She was in the second trimester, but unfortunately she died during therapy. We gave her the chemotherapy and she did not, her disease was so massive and it was CRC, colorectal cancer, but unfortunately she died and she was so young.
And the baby too?
Yes. She was in the second. He was premature to live in the incubator. So we lost both of them.
Just one more question, Umar. So because you followed this patient during the pregnancy with the image, so do you have a special arrangement with the radiologist regarding scans, how frequent, and is there any specific precaution and communication with the radiologist when you order for radiological image?
Yeah, it's very important this point. We met with the head of radiology that time, and we discussed with the many radiologists. The final decision, it was CT with the pregnancy dose for head, chest, it's okay, and upper abdomen. It's a contraindication to do CT scan for the abdomen. For this reason, we did MRI to confirm the mets in the liver. The pelvis, as they said, MRI with the pregnancy dose also it's acceptable. ultrasound, it's acceptable. X-ray, it's acceptable. We repeat the CT and MRI every 3 months, as I say in the case presentation, and everything go well, alhamdulillah.
We know a lot about cancer in pregnancy, especially in breast cancer, but I'm not sure if we have a lot of information with colon cancer. Am I right, or you have done that part?
I think we see more breast cancer on pregnancy rather than other malignancy. So because we are not, I don't think any one of us doing breast cancer, but I think we see a lot in breast. I've heard a lot of cases with breast cancer, and easy manageable because of the hormonal therapy.
Yeah.
Okay. Any question, Imad?
Today, I think we were exhausted from the questions. We were exhausted from the rich information. I think you guys did great. Congratulations.
Thank you.
Okay, so I think we reached to the end. I would like to thank our all amazing speakers. I would like to thank also Dr. Imad for the value and excellent questions and moderation. And thank you also for our attendees who stay with us over the weekend, and looking to see you again in our upcoming events. As Kanaan mentioned, we have the Precision Oncology in 2 weeks time, and hopefully to see you then.
Inshallah.
More comments. See you inshallah soon.
شكرا جزيلا.
Thank you very much.
يعطيكم العافية. نشوفكم على خير. مع السلامة.
الله أهلا وسهلا.
باي باي.